Hi everyone, this is Neil Writer, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. I sure hope I haven't already posted this. I've got so many videos and I'm losing a bit of track, so I don't think I have. I've had a quick look through, but apologies if I have already. Now, this patient attended with a bilateral wax impaction. They clearly use a Q-tip here because the center section of the wax is really impacted and this peripheral wax is more lateral, and it's really embedded against the canal wall, so it's quite sticky wax with a lot of skin, quite hairy ear canals, as you can see. So I'm just starting off with microsuction. I want to leverage this wax down off the superior canal wall, so the front part, and now I'm going to the back part of the ear canal. With this type of wax and skin, one of the difficulties is that it's a very similar color to the ear canal wall, so it's almost camouflaged, which means you've got to tread very carefully if you're working close to the ear canal, because you need to be able to distinguish between the wax and the canal. And this is a good example here. So this is at the floor of the ear canal. They've got this little green sequin just to the left. I've seen that in quite a few patients' ears, and I don't know what it is. I have asked them. I thought, is it some sort of facial scrub, or is it some sort of makeup? And the patient themselves didn't know, but it always tends to be green, so it's really weird. I've just put some medical grade olive oil spray because this is really impacted. I tried to lift it off the floor of the ear canal, but it wasn't budging. And that's another telltale sign that the patient has been poking their ears. So when you poke in your ears, you push the centre, depending upon where you position the Q-tip, or cotton bud as we call it in the UK. But if you're pushing it in the middle, it embeds the middle section of the wax deep, and then it squashes the peripheral wax up against the canal wall, and you can see it's really adhered. And I've got to be careful because we're right on the canal, we're on the bony part of the ear, so I'm using this sweeping motion. I'm trying to lift it up, but it's still really embedded. So I'm just looking for another section here. There's not much for me to kind of latch onto, unfortunately. If there's just in front of the suction tip, you can see a bit of wax that's raised. If there's a bit more there, then I could grab onto that and lift it, but it's well and truly squashed up against the ear canal. So I'm just looking for a different area. So I'm just going to the back part. Again, I just don't know how thick this layer is, so I've got to be really careful. You can see I'm coming inwards from right to left with the suction. If I just go in a straight line forwards, very likely going to bump into the ear canal. But it's rock solid. The suction tip is almost gliding off this. So change of tactic. I'm going to go to I'm sure in a moment, going to use the correct, and I want to separate it from the top part of the ear canal. It's quite a hairy ear, as I said. So with the correct, I'm just going to glide up against the ear canal wall. And I'm going to leverage it down. I had to put a bit of force behind this, so I'm really bringing the correct down, trying to separate it. But now I've got some purchase. It's beginning to separate, which is fantastic. And then I may go back in with suction, which you'll see. Because I've got more surface area to grab onto, suction may be a bit more helpful now. And I'm going to start peeling it all around the edge. And I don't know whether you can see right in the distance the wax is moving as I'm pulling this. So it tells me that this is all one section of wax and one plug, and the middle bit, there again, you can see just below the suction tip, the darker wax, which is out of focus because that's deeper. It's bouncing up and down as I'm peeling this. So I'm just on the anterior canal wall. I'm just bringing it left to right, trying to separate it. And then I'm pretty sure I'm going to go to the floor of the ear canal. And then I'm going to use the crocodile forceps. Now, when I first developed the WAXscope, it was purely meant for microsuction, because all of our manual instruments, so the ear hook corrects, etc., they're all straight. And with a design like the WAXscope, where you've got a camera, so in this case, you've got the iPhone behind it, you don't have the working space to use a straight instrument. So with the suction tip, we use a 30-degree bend in the UK typically, but some other parts of the world they use a 35-degree bend. But there's a bend, which means your hand that's holding the instrument is not going to collide with the device. But with the straight instruments, that's not the case. So whilst developing the WAXscope, I came up with the concept of developing angled instruments. They use them in dentistry, but they're not really used for earwax removal. I think they may be used for ear surgery, but they're metal ones. And although metal ones are effective, I don't really like the idea of training someone for the first time to use metal ones because, of course, they've got more surface tension and you're more likely to cause trauma. So the ones that I manufacture are carbon-filled nylon. So they are very, very strong, but they're also just got a bit of flex to them. So if you do come in contact with the ear canal wall, yes, it probably will be a bit uncomfortable, but less so than the metal stainless steel versions. So I'm just going to lift this up. You're going to see me purposely leverage this up so I can grab onto it with forceps, because at the moment, the bottom piece of the wax is quite close to the canal wall, and I don't want the jaw to when I open it to hit that. So I've just lifted it enough. You can see there's a little opening at the bottom. I'm getting that bottom section of the wax in focus. So initially I just want to lift it up. You can see the whole plug is rocking back. I've almost maneuvered it into the ear. So I'm just going to come out, and I want to get a good grip now, because with this type of wax, there's always a risk when you grab it and you're closing the jaws, you lose grip of it and it pushes it back in. But I've got a good grip. I'm going to pull this out in one plug. This patient's eardrum is quite interesting. They've got a really miniature handle of malleus, so the hammer bone. You can see the hammer bone in the middle. It's really, really small in comparison to the rest of the eardrum, but it got a stunning view there. Just looking at the annulus, that's the eardrum. So yeah, the hammer bone in the middle. The stalk of it, we call it the manurum. It's a lot shorter than usual. So this is the same patient. This is their right ear, but the consistency is completely different here. It's sticky, but it's not as dry and adhered as their right side. A bit more of a bendier ear here, and the entrance is a bit narrower as well. So I've just put some medical grade olive oil spray straight away because it's a sticky caramelly wax. Olive oil really helps to just change the consistency. So I'm just looking for an area where I can get a good grip. So I wasn't happy with that, so I just got a bit higher up. So I think the lower section was a bit too sticky. I think it's still a bit sticky here. I think just here I found a little spot in a moment where it's a bit firmer and I can get a better suction grip. You can just see how focused the view is with the WAXscope. It's just incredible optics that you've got. There is definitely, I think it's here. I've just got a better suction grip. So I'm going to just give it a little wriggle and come forwards. And see there's a lot of skin there. Now, earwax predominantly is made up of dead skin cells. Around 60% Western wax anyway. In the Far East, it's probably a higher percentage. Probably 80 to 85, 90 even. But this is predominantly, I will say this is a high concentration of dead skin. So earwax is made up of dry matter, so dead skin cells, called corneocytes. The corneocytes line the epidermis, the outer layer of the skin. And other dry matter that might be involved is foreign particles, bodies that may have entered the ear. The hairs, which you can really see with the WAXscope, more so with the endoscope. You can see the hair sticking out here. And then you've got wet matter. So wet matter is ceremonous sweat secreted by modified apocrine glands called ceremonous glands. They secrete an oily protein and lipid-rich sweat, and it's an emotional sweat. So it's not sweat that cools the body. So it's more of a flight-fight response sweat. So it could be, so sometimes patients, they do come and they're going through a period where they're secreting more wax, so they want to know possible reasons, and one of the reasons I ask if they become more stressed, or conversely, are they very, very jubilant and happy? And sometimes we can find a connection there. And also the other wet matter is sebum, which is an oily lipid secretion, similar to this, well, it's the same as sebum that we secrete on our forehead. That helps to moisturize the scalp and line all the hair strands. So I've just got it in focus. So all these, the two wet matter secretions, so ceremonous sweat, sebum, they're secreted in the outer third of the ear canal. and the dead skin, it migrates from the eardrum towards the entrance, and as it comes towards the entrance, those corneocyte skin cells that form the epidermis layer in the deeper regions of the ear canal, they're interlinked. So you have sheets of corneocyte skin cells. But as they approach the outer third, they begin to separate and flake away in individual skin cells. So all of it amalgamates together and forms earwax. So it's quite a sticky one, as you can see. The other one is really, really dry and crusted and embedded. This is more caramelly. Now, I think at the end of the video, I tried to visualize the eardrum. I'm using the medium-sized specular, but it was a bit difficult to visualize because they've got quite a narrow first isthmus. So the first isthmus, you can probably see it. So on the left-hand side where the specular is, you can see a bit of flesh. That's the first bend. On the right-hand side, that's the second bend. Now, I've straightened it quite a lot with this specular, but I couldn't get it any further in. So I did revert to the smaller size specular to have a final look at the eardrum, but I didn't record it, so you may not see the full eardrum, but I just changed specular. But I managed to get that in a plug. So you can see it's quite bendy. The eardrum is veering off to the right. So I'm just going to mop up some of this sticky wax skin from the roof of the ear canal. You can see all those hairs. So I can't remember the patient, but I'm assuming they were male. Male patients tend to have these more terminal, thicker hairs on the outer third of the ear canal. It's not to say that women can't, but generally speaking, it's more older patients who are male. Asian patients, I'm Asian myself. I know I've got a bit of thick hair in my ears, so it's probably a bit more common with Asian patients. So you call that auricular trichosis when you have really, and that auricular trichosis is not just hairs in the outer third, but it could be on the pinna, so the outer satellite dish. So I'm just trying to mop up some of this sticky stuff, and then I'm going to try and look at the drum. I get a half decent view, and I can see what I need. But I did use the size 1 specular to get a better view. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon.